Okay, Kevin, thank you for the wonderful introduction. My name is Chris Felix. I'm a material scientist with about 20 years experience working with dental materials, light cure materials, curing lights. I've done lots of work helping manufacturers develop lights and materials. And I've also spent a lot of time visiting dental practices and helping everyday practitioners understand the complexities of light curing so that they can, maximize the success that can be had with procedures that use lights and light cured materials. So disclosure, I do work for Blue Light Analytics, which I have a financial interest in. We don't make lights and we don't make materials. However, we do have products and services related to light curing research, education, and clinical practice. And so certainly I'd like to throw a big thank you to Garrison Dental for inviting me to speak today. So our agenda today will cover the critical role of light curing. It's something that sometimes isn't front and center. However, light curing really is a fundamental part of everyday dentistry. And so we'll really kind of discuss the ins and outs of light curing, how inaccurate light curing can impact the performance of materials, the procedures done on patients, and certainly the everyday practicing clinical staff that needs to understand all of the different issues that can come from not managing light curing in your dental practice. We'll also talk a little bit about some of the key factors in curing like design and performance and how that can affect your materials and of course your procedures. We'll also do a little section on safety and maintenance around curing lights. And then we'll finish off with some tips on what to look for in curing lights. As curing lights have evolved significantly over the last 20 years, the technology certainly has advanced, and we're going to tell you what to look for in your next curing light. And then we'll cover it off with a summary and some key takeaways, and we'll open the floor for a Q&A session. All right, the critical role
Just
of
for a
light.
quick second, Chris, I wanted to mention you can type in your questions at any time. Use the little question box symbol over on the right hand side, upper right hand side of your screen. We will wait until the end to go through them, though.
Sounds good. Thank you, Kevin. So we started to get together as a group of dental materials researchers back in 2013. Really was the first group that got together to discuss this issue around light curing. And myself, having worked with Dr. Richard Price at Dalhousie University in Halifax, Nova Scotia, doing research on the performance of lights and interaction with the materials that are designed to cure, so composites, bonds, and cements. And so we really began to learn a lot about the complexities, the complex physics and chemistry that is happening in a patient's mouth, a very harsh oral environment to get materials to function properly. And what was nice is that I think it was in 2023 where Dr. Gordon Christensen had attended the meeting, was in Toronto, and again, began to really acknowledge the complexities that exist in these interactions between lights and light cure materials, and came out with a pretty strong statement in one of his publications, really acknowledging that light curing really is one of the most underestimated or negligent areas in restorative dentistry. And that it's something that everyone needs some education on. And again, over the decade of meetings, really began to highlight the gaps in education at the dental schools, at the dental assisting schools, which also is very important because a lot of the time the dental assistants were doing the light curing. And so really we're going to dig into some of the information that we've assembled through these meetings that is really meant to help the everyday practicing clinician to make sure that these challenges or issues don't present a problem in your practice. Again, in really highlighting the importance of light curing, you think in the run of a day, the procedures that are done, over 50% of them use a dental curing light. So whether it's direct restorative, indirect restorative, doing post and course after root canals, doing, veneers, crowns, bonding orthodontic brackets or composite buttons for clear liners. The curing light is just used day in, day out, and it really is a device that needs to work and function and is really responsible for a lot of your production. And we'll dig in a little bit deeper into this statistic, but up to 12% here, we're talking specifically about class 2 restorations, which generally are some of the more challenging class of direct restorative restoration, can be lost in the run of a year due to practice and operator factors. So these are factors that if you know and you can account for them, that they can be eliminated. It's very difficult to have a 100% success rate. However, you can get pretty close to it if really managing a lot of these different complexities that have been introduced really with like cure composites that really didn't exist when placing amalgam. Amalgam, was a much easier material to place successfully, where bonded direct composite restorations do have a few more steps to be aware of the tips and tricks to be successful. So here's a section where I'm going to talk a little bit about materials as well. I don't normally go too deep into the materials in this presentation since it's more focused on light curing. However, in a class 2 situation, the materials you use are really important in preventing postoperative sensitivity. And of course, postoperative sensitivity can certainly bring patients back in within days or weeks after a procedure. And then the troubleshooting process begins of, why or how or what went wrong. Is the postop sensitivity going to go away? Is it not going to go away? Does the restoration need to be redone? And so really, with a few things to understand that I've picked up over the 20 plus years of talking with dental material researchers and practitioners, with a procedure, a class 2 procedure, you start off with cutting the prep. Now, one of the first things to see here is that total etch, acid etching, a really deep prep. You might want to do selective etching to the enamel. Dentin is quite porous and is quite easy to bond through if there's no contamination or saliva to it. If it's prepared well, it will bond well. However, that acid down into a deep prep, if there's only a little bit of dent in there separating the pulp chamber, this is where some amount of acid, if it doesn't get washed away, can begin to irritate the pulp after the procedure's been done and the patient bites down. And again, a very similar thing when you're laying in the bonding agent itself. Again, when you have less than 0.5 millimeter of dentin separating the pulp chamber, this is where some of the bonding agent can cause some temporary irritation of the pulp as well too. So I would certainly suggest considering if it's a really, really deep preparation where there's very little dentin, you may consider using a liner type of material, a glass ionomer, or something that doesn't require the etch or the bond to, again, protect that pulp. Also, there are some materials that have some desensitizing components within them, and that will really help. Even if the restoration is done really well, is to prevent some of these irritants from getting through a very thin increment of dentin and causing that sensitivity, which most likely will go away after a couple of weeks. But if you can prevent the patient from feeling that, that's also quite helpful. Now, as you get through your procedure and you start to lay in your bonding agent, what's really important here is now you need to light cure the bonding agent. And so cases where, let's say worst case scenario, you're doing a distal class 2 on a molar, and you need to get that curing light down and on top to make sure all that bond cures. Certainly if the light is at an angle and one of the walls is obstructing light from getting to the bonding agent, and there's any bonding agent that remains undercured, absolutely this is going to cause sensitivity, debond, secondary caries. And so again, making sure that the light is positioned very well to cure the bonding agent, especially in those posterior regions, is absolutely critical to avoid post-op sensitivity. And then as you kind of get into the filling step, Here's where, some are still using conventional 2 millimeter increment composites to fill up a posterior restoration, especially a class 2 restoration. You might have, 6 or 7 mils to fill. It's really tough to stay under 2 millimeters when you're placing an increment in a posterior location. This is where I do recommend looking at some of the newer bulk fills that you can place up to 4 millimeters, some cases even 5 millimeters, to make sure that you stay under that maximum increment that's recommended in the material instructions for use. So, moral of the story here is if you place 3 millimeters of a composite that only has a limitation of 2 millimeter increment, the bottom will have a very difficult time curing. And in the back of the mouth, it's quite hard to see how much material is being packed in. And so, especially with almost 3/4 of the restorations done being in the back of the mouth. So again, the newer bulk fills really help to speed up the process as long as they are fully light cured quite well. So again, for those of you that haven't incorporated a bulk fill for those procedures, it may be worth looking at for several reasons. But however, of course, whatever composite you are using, it needs to be fully light cured. Again, the light being positioned quite well. And so those are two areas in this direct restorative procedure that are absolutely dependent on the light curing component in this case. Now, the impact of what happens when a material doesn't get enough light to fully cure. This is quite well tested in the lab when we test materials. They can when they don't receive enough light, they can very much discolor easier. They wear faster. They can break easier. They can debond easier. And of course, these are all issues that can lead to secondary caries, post-op sensitivity. And so certainly, we need to make sure that these materials, as they were designed and tested in the lab, in a clinic, in a patient's mouth, that they're also able to receive the light energy they need to fully cure. Now, if you go back 20 years, and you had curing times of 40 and 60 seconds with low power halogen curing lights, you never had to worry about overcuring these materials because of the heat the newer lights generate. So lights from today that are over 1,000, some even over 2,000, and depending on the time you're using them, a new issue has been introduced with high power curing lights. And there are some lights that can generate 2,000 milliwatts per centimeter square and can run for 20 or 30 seconds, which certainly is enough to damage the soft tissue or the pulp in some situations. And so, really now you can't just overcompensate, to deal with undercuring. There really is a safe zone of where you want to make sure you've delivered enough light energy that the material is cured, but not so much that you can damage the soft tissue, like if there's a class 5 near the gums, or if you're doing a really large restoration where the pulp chamber has very little dentin separating, to the pulp chamber. A lot of heat can be passed into the pulp, and so a lot of these issues can present as the patient coming back with post-op sensitivity, and then it's a matter of troubleshooting. Well, why are they feeling this? And it can be really from a number of different reasons. So, the other impact certainly is on the patient themselves, is understanding that, when things go wrong for the patient, they feel post-op sensitivity, they'll see, their restoration discolor, of course, secondary caries and fracture, having to repair that restoration or completely replace it, certainly wears down on the tooth until, potentially endodontic treatment is needed or an extraction. And so I've seen, the escalation in care when things go wrong for the patient, and certainly there is, a physical, mental, and financial pain associated with that. So certainly we want to make sure we're doing everything we can to make sure that we're providing the best care to our patients. Now, I tried to tell some of the stories of real stories that I've come across, and I've come across several in the last couple of decades. And this was a practice that had noticed a spike in post-op sensitivity, and they had 37 patients come back in about a 6-week period. And the dentist there was, was questioning, first of all, the materials, a lot of the issues present in the materials, as we talked about, discoloration, debond, fracture. Was wondering, is my material? Should I change my bond? Should I change my composite? Is it my staff? It was my assistant not paying attention to what they were doing? Was the light set in the right mode, the right time? Then was starting to wonder, is it my technique? And, did I put too large of an increment? And then, you default back to, well, maybe it's the patient's hygiene. There's an issue with the patient? And again, this was happening over and over, and it was unusual because this was a spike. It hadn't been always this way. Then the office manager had reached out to us and had thought of the curing lights. And, we helped them get their lights tested and found that two of their three lights were critically low. So still producing blue light, but nowhere near enough to cure a deep posterior restoration. And it was very evident right away when we tested the lights. And so, all of the 6 weeks where, the dentist had, was really very stressed, losing sleep at night, dealing with emergency return visits in the middle of an already hectic, busy scheduled day. The clinical staff was stressed. Everyone was stressed out. The unbillable chair time. And the fact that, patients were not happy, and there was no real, explanation that they could provide at the time. And so when we're able to identify the issue here, we followed their progress as well. They ended up buying two new lights, so they had three good working curing lights in their practice, and the issues went away. And when we did kind of a cost estimate of the cost of these 37 patients coming back, it was about $10,000 in lost productivity. So again, this really turned into a nightmare of a situation, which can happen anytime. Any curing light can fail anytime if they're not regularly being monitored. And this is something that is not uncommon, unfortunately. Before lights kind of get moved to the back of the room or given to hygiene, before they figure out that they're not working properly, they can really cause a large loss in productivity. And actually here, I know the video quality isn't overly great, but here is a light we actually got back from a practice that was using it when we identified that it was no longer a good working order. We brought it back to our lab and did a little test here where we took a class 2 mold and did a 3 increment build up. And we did it with a good working light and with a light that was found to be defective. Its output was around 266 milliwatts per centimeter squared, so nowhere near enough to cure a restoration. And so what this is showing here is that although the material was hardened, and if you took a Dental Explorer and you tapped it against the material, you would think that it was hardened and cured. However, a tiny little bit of force on the bottom of that box as I pulled it out of the mold, the material begins to fracture. And, again, these materials are very strong materials when they are fully cured. And it takes quite an enormous amount of force, as they need to hold up under a very large amount of force, especially in the posterior teeth. So you can't really tell all the time if a material is not fully cured. Even if it's hardened, it may still fracture. So material fracturing certainly is an indication it was never cured very well to begin with. And here's another analogy that we use sometimes, and so it's the baking the cake analogy, and where trying to bake a cake and you have it in there for several hours at 100 degrees Fahrenheit. The cake is never going to cook. It's always going to be soft on the inside, uncooked on the inside, and where the recipe says somewhere between let's say 375, where 350 to maybe 420 Fahrenheit likely will get the job done. There might be a little adjustment in the time. And then if you try to bake a cake at 900 degrees Fahrenheit, you're going to basically burn the outside, and the inside is going to be undercooked. So it's quite a fitting analogy to like curing composite materials, especially composites. As you're curing conventional or bulk fill composite, especially a 4 millimeter increment of composite, you can like cure it with 300 all day long. And to be honest, it very likely will not fully cure all the way. Same thing if you're trying to blast a bulk fill with 3,000 milliwatts per centimeter squared for 3 seconds, or a shorter period of time. It's just not designed to cure that way. Most conventional materials are not designed to cure that way. So there is a range where you can use 800 and cure for 20 seconds, or you can use 1200 and cure for 10 seconds. So there is a range there, depending on the recipe for the material, of course, which is the most important to follow in ensuring that materials are well cured. So certainly, if you're talking about a bonding agent, well, that's a thin film. It does cure quite easily, although time is a factor as well. Time is much more of a factor in a flowable or bulk fill composite, because now you've got a large increment of material that light needs to get through, and really only about 5 to 10% of the light gets through a 2 millimeter increment of a conventional A2, A3 material, as well as maybe a 4 millimeter increment of bulk fill. So, really it's about getting light through the increment, because the top surface will cure quite easily, but it's really the bottom where it needs to bond to the two structure below it, especially in that class 2 situation, where it's paramount that the material is fully cured all the way through. So, there are instructions for the materials, and each material has its own set of instructions. There's not a lot of standardization. However, there is bits of information that are critical to pull out of your instructions for use. And so typically, they should present an intensity of the light, either a minimum intensity or a range. If the light is within a range of intensity, they'll then present a curing time. And some materials may only have one range where they'll say, okay, anything over 400 and you can cure for 20 seconds. Where a lot of the newer materials have acknowledged some of the higher power curing lights and have provided a range where the curing times can be reduced in some cases. And so, if a light is over 1,000 milliwatts per centimeter squared, in this case, you can get to a 10-second curing time for the lighter A2, A3 shades. And so it's really important, again, to know the actual output of your light in order to know what's the optimal curing time to use, to make sure you're using enough time, and also making sure you're not using too much time there. The other thing some of these materials have broken down in their instructions for use is the type of light. So although halogens have really, I'm pretty sure almost all but phased out, LED curing lights really make up the majority. There are a few plasma arc lights, the sapphires, that are still out there. And there is a laser that's out there. However, a lot of the materials don't have curing times for the laser, and that's a whole other category of light source that requires a lot of safety concerns. So again, LED lights, a good working LED light, is what's the norm today. Also realizing that some of your materials might have different shade categories. So in this case here, the lighter A2, A3 shades are broken down into a certain material increment here, which is kind of the last thing to notice here. So shades of composite, the increment, the time, and the intensity. Those are the bits of information that are really critical in the restorative composite instruction for use. And then making sure that you know what your light is outputting, so that you can figure out, okay, well, what's my optimal curing time for my specific light, and then realizing that you may have several lights in different operatories that may perform differently and may require different curing protocols. So that's really important to sort out now. This is where some will say, well, I could just cure for longer, or I just cure everything for 20 seconds. With a high power light, you do want to make sure that you're not curing for longer than you need to, or if you are, implementing heat management techniques, which we'll talk about a little bit more in some of the next sections. So as these instructions are developed by manufacturers who make materials, it's also important to know that these materials are often tested on a lab bench, with the light perfectly centered over the material, sometimes, or not sometimes, most of the time, at a 0 millimeter distance from the light tip, and the light is directly perpendicular over the material, and there's no movement. Everything is clamped in place. And then, let's say a depth of cure test is done according to the ISO 4049. That then helps them generate instructions for use for these materials that are used clinically in a patient's mouth in an environment where a light may not be able to be perfectly centered over the material, or might be at an angle, or might be at some distance, or might have the patient or the operator moving around. So there really are a lot of variables, clinical variables, that may not be taken into consideration when a material has generated their instructions for use. And having tested many, many, many materials over the years, I can comment on some manufacturers will provide a significant cushion on what they're directing you to light cure. They might have like a 20 or 30% cushion on top of where if you make it to 70 or 80% of what they're recommending, everything will still be fine. However, not every company is equal. There are some companies that want to give you the shortest curing time possible because that's maybe a good marketing strategy. However, if it doesn't receive exactly what they say, anything less than that, then this is where some of these issues with materials can present. And so, for yourself, it's hard to really know what was done in generating those instructions for use. But what is for sure important is that if you can deliver at least what the instructions are saying, you should be fine. Now, it's a little bit more complicated than that because then you do have to account for some of these clinical variables. For instance, distance or angle or positioning, and we'll talk a little bit more about that in some of the next slides on how to manage some of these clinical variables. Now, getting into studies, in the research world, we're always asked, well, why is light curing important? Where's the paper that tells me, that if light's not working and it's going to cause a failure in a patient? And of course, there is a lot of ethical issues with using a defective medical device to implant a product in a real patient. So unfortunately, a lot of our studies are done in the lab where we test materials and we undercure them and we see what happens. We see if they discolor, they debond, they fracture, and certainly at what point these materials are fully cured to develop those instructions for use. Now, but what has been done, and this was a really great study it was published back in 2019. It looked at over 31,000 direct restoration, direct class 2 restorations, specifically, knowing that these are the more challenging of the group. Just looked at data from real practices. And so what was really interesting is it looked at, over the next year or two, the different failure modes. And so again, they looked at a number of different variables. And what really came out of this large data set was that there was a large difference between operators. And so when they looked at the differences in the materials, again, it wasn't that big of a deal. They looked at all the patient characteristics, older patients, different hygiene issues, bruxism, which absolutely plays a role. But when they normalized all of that out in this very, very large data set, there was still a huge difference between operators, between practitioners. And so what this was showing is that not everybody's success rate is the same. And when you normalize everything out, you could see some operators, their success rate, which was excellent, was at about 97%, looking at the annual failure rate. So reintervention happening over that year. If you could have 3% intervention rate, especially in a class 2, that is an excellent success rate, and it's absolutely achievable. However, there are several things that as an operator that you need to be aware of and to manage to make sure that they're not causing issues. So whether it's isolation is one that can cause the bond to not set properly, and of course then the secondary caries and recurrent decay causing that issue. And then light curing absolutely is one of those factors that can contribute to up to a 12% loss or reintervention rate within that first year. And so then it's a matter of, okay, no, do you need to redo that? You may not be able to charge for that. And of course, this is where those issues of unbillable chair time, stress, having to redo it, not knowing what went wrong. And so what's really important about the study is that it shows that there's things that operators can do to maximize their success. And light curing absolutely is one of the really important ones to manage. So now we're going to switch gears a little bit, and we're going to talk a little bit more about, the design of curing lights and their performance. Certainly, as I mentioned, LEDs have taken over. Some of the older halogen lights, they had their issues, and one of the things that misconceptions, I guess you could say, is around LED curing lights, and that they're going to run, 10 or 50,000 runtime hours, without any issue at all. And when they finally stop working, they work perfectly until the day they stop working. And like any light source, light sources tend to go through a process of degradation or different issues that can happen to them. So that a light can appear to be working, the blue light can still be turning on, but there's no guarantee unless you're able to measure it that it's functioning as it was when it was new or as it was designed. And if you look at the instructions for use for a lot of these, regular testing and maintenance, which we'll get into a little bit later as well, are absolutely important in ensuring that the equipment continues to work as needed, as intended, day in, day out. But design. So design has really changed in the last 20 years from the older halogen lights that used to come with, 12, 13, even 14 millimeter guides. They were very easy to cover, a full surface of any tooth. And, and you'd run them for 40 to 60 seconds. So a real slow cure within reason. So again, it was quite simplistic, good coverage. And then the trend became, okay, well, how could we reduce curing times? Well, we can reduce curing times by increasing the intensity of the light. And one way to increase the intensity of the light, was to actually put a smaller tip on it. So around as the halogen lights were coming to the end of their era, they started to come with 8 millimeter guides versus the 12, 13, and 14s they used to come with. Simply because intensity is measured in milliwatts per centimeter squared. And milliwatts is power, centimeter squared is area, and your light tip is the area. So if you're able to reduce the area and you have the same power, you're going to get a much higher irradiance. And so what you can do then, like I mentioned, within a reasonable range, is start to reduce curing times. And this is what happened, where curing times for materials came down from 40 seconds, then to 20 seconds, then to 10 seconds, and then some other things to get curing times down a little further, which are more on the chemistry side, which we'll chat a little bit about. But just on the tip size. But one of the issues to remember is that as you're making that tip smaller and smaller, it gets harder for a user to actually overlap over where the material is being placed, especially in a posterior restoration. So lights were actually getting harder and more, technique sensitive is the way I kind of describe it. The technique required to make sure that smaller tip is over the area where the material is placed is much more challenging. And so light curing actually got much more challenging. And the other aspect of the light tip is the angle at which the light tip is made. These fiber optic glass tips, some of them have really poor angles where it's almost impossible to place a flat on the surface of an occlusal surface of a molar, where the patient just simply can't open wide enough. And then again, the light tip will be placed at an angle. And as I mentioned, if it's a distal class 2, where the anatomy of the tooth begins to block the light's delivery to the light cured material. So of course, as lights developed, having a light with a lower profile is absolutely much easier to place, again, on a distal buccal, or anywhere really in the posterior locations in a patient's mouth. So again, those are things to really pay attention of, because if a light is much harder to use, this is going to increase the variability in the light cure of the material and the variability of the success of that procedure. Now, how the light comes out of the light tip is also very important. We had a look at many different lights where we put it on a camera, a laser beam analyzer, and look at the distribution of the light. I think there was an assumption that the light was nice and even spread out over the light tip, but unfortunately, depending on how the optics are designed, we see one light here where it's almost like a spot welder, almost like a tacking tip, to be honest, except that it was an 8 mm tip with all of its intensity directly in the middle. And the intensity was almost 10,000 milliwatts per centimeter squared, right in that small fine point. So if you're using it for 1 or 2 seconds to tack veneers, maybe that would work. But trying to light cure a moderate to larger restorative procedure, it likely is going to leave some degree of some margins quite undercured. And so having a light source that has a relatively uniform beam profile really is quite advantageous to getting a nice uniform cure to your restorative material. And so, now with especially as we look at the beam profiles overlaid over the MOD we have here cut in the premolar, you can see in some cases where, depending on the positioning of the light, there could be a critical margin or two that simply are not getting the intensity of light needed to go to and through to ensure that margin holds up. And of course, if the margin is cured, at a shallow depth and not all the way down, then of course it eventually will let go and debond, and secondary caries will begin to form after that. So again, getting good coverage, good beam profile, absolutely critical. And a lot of light manufacturers, well, maybe not a lot of the good manufacturers now are starting to provide this information with their lights to let you know that their light has a moderately good beam profile and is not one of these ones that have these pronounced hotspots. Now, distance is another thing that's quite important. As we mentioned a little bit earlier, a light can be at a distance. If you're doing a deep class 2 buildup, certainly you want to make sure that the light is able to know how your light performs at distance. So some lights can maintain their intensity quite well over clinically relevant distances out to about 10 millimeters. Some will moderately drop, where at about 5 or 6 millimeters, you may need to double your curing time for that first increment being placed at the bottom of a class 2. Some lights will drop off very quickly, like a point source, because it doesn't have any optical components helping to collimate its beam, and you may need to triple or quadruple your curing time, just to get that enough light to reach a deep increment in a class 2. And at some point, it may not even be able to get enough light through that increment. So again, having a light that performs well at distance certainly is a huge advantage. Photoinitiators is another thing to be mindful. Depending on the material, the composite you're using, the older halogen lights had what was called a broad spectrum, which had a degree of violet light as well as blue to cure the various photoinitiators. Camphorquinone being one of the more popular initiators, it's activated with blue light. However, there are some other initiators that benefit or require the violet wavelength. So again, it's important to know the materials you're using, whether they require the violet component for some of the other additional initiators. Certainly, all the materials need blue, as camphorquinone is in all of the intraoral light cured materials. The next one, I mentioned a little bit about modes in curing lights. It's important to be able to identify what mode your light is in and make sure it doesn't get accidentally changed to a ramp or a pulsing mode, which sometimes happens. So knowing what mode you're in, to be honest, a standard output mode is actually all you really need. Some of these ramp and pulsing modes were a little bit of a fad that under some conditions in the lab may be able to show some benefit, but with all the variables in a patient's mouth, having a consistent, reliable, adequate output is really what you're looking for in a good restorative curing light. Here's the difference in quality of some lights. So here's a higher quality curing light that Here's about 5,000 lights that were tested of a particular model. And these lights, these lines here are the lines of where the plus or minus 20% of where the light should fall into. We can see here some of these lights are probably 10 years old, and you can see some of them have faded out a little bit. Some of them a little bit higher because they actually had a light guide on it, a smaller light guide, which actually increased the output. But what I want to show you is the difference between a quality curing light, a moderate quality curing light, so kind of in the middle of the road. Now look at the scatter of all of these measurements. So it's almost, over 2,000 lights of a particular model, all the same model, but several lights in private practice. And now look at the scatter. So you got several lights that are, quite higher than what they're supposed to be, and then several lower. Now, the next slide here is from a low quality model curing light. And just to show you guys a little snapshot of the difference between a higher quality light and a lower quality light, look at the scatter of the measurements from, almost a little over 1,200 models of light here of the same model. So again, you think, you buy a light and you have 5 of the same model. Well, the output could be, anywhere from, 100 to 2,500. And so again, very inconsistent, which is going to lead to a very inconsistent procedures and results. And so again, looking at that, look at the difference between a quality made light and something you would find, on eBay or Amazon. So again, really, really important to take that in. And again, with light curing, when we look at the dollars and cents of light curing, and we look at a curing light as a cost of goods and in the production it's going to be involved with. If you take let's say a class 2 restoration, and let's say we estimate the cost to the patient at $300, and we break down the cost of that $300, we can see here very quickly that the wages and benefits of the clinical staff's time, the assistant and the practitioner, their time is the most valuable. Your guys' time is the most valuable that goes into the cost of goods of doing a class 2 restoration. The other larger portion is like the cost of the office and the overhead and the rent, and and then about a little less than 10% of the cost is broken down into the consumables, the materials, and then a very fraction of that is actually the curing light itself. So less than 0.2%. If you take a $1,500 curing light and assume it'll last for 4 years and throw it away, you're at about 60 cents on the cost of a $300 restoration that goes into a good quality light. And so, again, it's trying to really think of it as a cost of goods. Because if you go and buy a $50 curing light that might cost 1 cent, in that whole cost over 4 years, however, it'll never last 4 years. As patients come back, as that light begins to fail, and these procedures need to be redone, it doesn't take too many procedures that need to be redone in that 4 years before it would have actually paid for that quality light in the first place. So again, dollars and cents there. It's really valuable really important to have a good quality light, and cheap lights, as much as they're cheap up front, they have a huge cost, over time as they begin to fail quite quickly. Now, here's a little video on light curing training here, and so I'm just quickly gonna show this here. This is an assistant who has not been light trained before. They're positioning the light. They're kind of looking away. They were on the right spot, but if you look at the little screen, you can see that the light is really moving around and is moving off of the tooth, and so this can happen quite easily if you're distracted. Someone is talking to you for that 10 or 20 seconds, even for that 40 seconds way back. You can get distracted quite easily, and so it's really important in that time to focus. And when we had actually developed our first simulator to do an educational course, and we tested some dental students, we could see that their results were quite all over the place. And really, it was an aha moment for us that, okay, well, this hands-on technique is not really being taught. And if we're able to measure their light delivery and they're not delivering enough energy that the material needs to be successful, maybe this is why these direct restorations are failing, or at least a significant contributor. And certainly, as we began to teach light curing skills, and again, they're not overly complicated. In knowing your light, adjusting the light tip to make sure that it's positioned well. It's not in an awkward position where you can get it flat directly on top of the material, positioned well, stabilized. The light operator is looking at what they're doing and they're focusing during that time. Again, it only takes 10 or 20 seconds to contribute to that whole procedure failing. And so this is the time, again, really to be quite focused. And so for you, for you practitioners out there, if your assistant is here tonight or not, making sure your assistant is really picking up these tips and tricks. It's really important, because if you're not on the right tooth, or if you're half off, half covering the material, it's not good enough. The procedure is going to fail. It's just going to be a matter of time that patient is coming back, first with sensitivity and then with the escalation from there. And so this was one of the first groups we had ever trained at the university. And after a bit of training, we were able to get them to be much more consistent in their energy delivery and start meeting the minimum energy requirements that were in the material instructions for use. Few words on safety and maintenance. Protecting your eyes is really important. There's different eye protection options that are available. Some of these little light tips, you have to be careful that they don't obstruct your view or create distance. As we talk about, distance is not a good thing. If you're light curing, you want to get as close as possible without sticking the light or the barrier into the material. You can even light cure, a couple of millimeters away and then bring it up to the material where it'll be cured enough where it won't stick. Having the assistant hold the paddle is another one if you do four-handed light curing. Getting some glasses if the assistant is doing the light curing on their own to use their two hands to hold the light and stabilize the light tip. Just looking away and not stabilizing the light is a recipe for disaster. I can tell you 100% it will contribute to procedures failing. So again, stabilizing the light, making sure that it's positioned well, as close as possible. These are things that are quite critical to do consistently every time, so that your results are consistent every time, or as much as is possible. Talked a little bit about the heat concern around curing lights. Two situations that to be aware of is if you're doing a class 5 and half of the light guide is over the gingiva, and there's no rubber dam in place or anything, like the light is directly over the gingiva. With any of the newer lights from today, you really have to be quite careful. 10 seconds with a light around 1,000 to 1,500 is about okay. If you do 20 straight seconds here, it is definitely going to irritate the gums, and the patient will definitely feel it. You only need to run your light on the back of your hand to feel how hot it is. To know that you have to be really careful in these situations to make sure that it's not overlapping the soft tissue. Make sure just the edge of the light lines up with the tooth. Would be important there. The other situation where light or temperature or heat from a curing light can be an issue is if you're doing an MOD or even a class 2, but an MOD especially, where there's a large area of that's on top of the pulp that's exposed, and you might be doing liners or buildups on the proximal boxes, and realizing that this is where a lot of temperature can transfer to the pulp chamber. So again, if you have a high power curing light, you do not want to use it for more than 10 seconds for a moderate output light of about 1,000 to 1,500. Again, you just want to prevent transferring a lot of heat into the pulp chamber. Now, if you pack your bulk fill material in there, or you've done your build-up with your conventional, and you've now covered the top of the box where the pulp is now insulated with a couple of millimeters of composite, you can light cure full intensity for 20 seconds straight, and it will not build up enough heat in the pulp to damage it. So it's really in these situations where the pulp is vulnerable or the gingiva is vulnerable that it's worth being mindful there. Another thing to pay attention to here is infection control barriers, making sure that if you have an opaque barrier that you use, stop using it and get a clear barrier. These opaque barriers really do cut out a lot of light. Lights that have cracks or crevices or joints between the composites, not between the composites, between the components. You're really going to want to use a barrier to prevent material and contaminants from getting stuck into these cracks and crevices that can't be easily wiped or removed. Of course, with the glass guides, again, you want to make sure that the barrier is nice and fit, flat and flush. There's no seam in the front, and then really the barrier won't have any issue at all. You don't want to wrap it around several times with food wrap. If you do use food wrap, again, one layer is good enough. And of course, it's a single use, something that each of these barriers are single use. So you want to make sure you use a new barrier every time if you need it. If you're not using a barrier, then of course bond and composite can stick to the light tip. You need to remove that every time. You can't leave any material on stuck on from previous patients. A little bit of alcohol, soaking it in, plastic instrument to chip it off. Any damage to the glass, of course, you need to fix, of course, because that's it's a sharp glass eventually that develops there. Any plastic bits there that are stuck on, or that are missing, I should say. Sometimes these plastic pieces can come off. It's important to make sure that they are replaced. And so really, again, and making sure any damage or debris is addressed is very important. And now this is why, here's a couple of images of lights that we have found in practices that had, LEDs burnt out, and a light here that was actually dropped and broke on the inside. And so the office had no idea, because of course the blue light was still turning on. However, the output was severely degraded. And again, it's really important to know this. So, you really need to be testing your lights to make sure that they are working, because every light will fail eventually, and any light can drop on the floor. And again, as technology evolves, of course, it would be great to have a curing light that would let you know if there was any change to that output, so that you would know right away. So at this point now, we're getting close to the end here. I'm just going to cover a few summary points and a few high-level takeaways, and then we'll open the floor to our Q&A session. So again, really important here is what to look for in a curing light. And I won't tell you what light to buy, but I'll tell you certainly what to look for. You want a light that is consistent. Consistency in your equipment is going to give consistency in your procedures and clinical outcomes, hands down for sure. Today, most high power curing lights, which would be moderately high power, because there are some that are very, very high power, fall in that range of about 1,000 to 1,500 milliwatts per centimeter squared. And curing times for a light of that power generally falls between 10 seconds for A2, A3 shades, and maybe 20 seconds for some bulk fills, although there are some bulk fills now that I think you can even get down to 10 seconds within that range. There are some, some composite restoratives that, have special chemistries in them that, that can allow a faster cure, but it's important to remember that a material that doesn't have a special initiation system, you can't just light cure it for less than what the manufacturer is recommending. So again, most composites, if you can light cure them for 10 seconds successfully, that's a pretty good moderate period of time. If you're doing ortho brackets, of course, there you're into 3 to 5 seconds with a light that is in that higher range. So if you have a light that does have a mode in that 2,000 to 3,000 range and a curing time of 3 to 5 seconds, you can do ortho brackets with it as well. But you then also have your restorative settings as well. So looking for a light, again, that can do that is great. Now, looking for a light that performs well at distance, I'd say. So you don't have to increase your curing times if the distance is larger, is very important. So if you can find out, if you're considering a light to learn, how is its performance at distance, most lights you'd have to double the curing time if you're doing that first increment at the bottom of class 2. However, if you have a light that performs well at distance, and then you can light cure, in all situations for 10 seconds, making that protocol consistent, across all situations is the ideal kind of situation. If you're using materials that require, violet wavelengths, very important to understand that, to know. There are some composites that are, especially some of these faster curing composites, they're able to achieve this with a combination of multiple photo initiators. So again, it's really important to understand that if your material does require these violet wavelengths, you have a light that is producing the blue and the violet wavelengths. It's absolutely critical. If you're considering buying a light, ask the company for a beam profile. It's getting more common now. These tests are more accessible. You want to know that you don't have a light that has a real predominant hotspot in the middle, because then what you have is really a veneer tacking light, tacking tip, and not a great one for doing restorative. And again, having a light that has a low profile is really, really important. And I would say now today, like with at least a 10 millimeter tip, which is about the size of, of an occlusal surface of a larger molar in an adult, so that you can cover the entire surface. There are larger tips available. You can get a 10 or a 12 millimeter tip. However, you're then trading off this much larger area. Your intensity is going down and your curing times go up. So 10 to 11 millimeter seems to be ideal. You have good coverage, good intensity, access to the lower curing times. As long as this profile is relatively uniform, I would say, look for that. Another thing to look for is, especially as the age of smart curing lights is kind of dawning, and curing lights that have extra features that can sense whether you're over the tooth or over the soft tissue, or won't turn on accidentally unless it's near good proximity near the tooth. There are some new technologies coming in the light curing area, which are really amazing to help users manage some of these challenges we have been talking about. So I'd say, really go out and learn, what's available for light curing technology today, because it is constantly evolving, and you want to make sure that it's successful. The technology is successful in your hand or your assistant's hand. Some final things here, for curing lights today, making sure the material is any gunked up material is removed, that lights are cleaned, and disinfected properly, and then tested regularly. Having some means of testing your light to know that it's working is critically important, because without that, the patients become the detectors of a failing curing light. And whether it's 5 or 10 or 36 patients that come back, it can be a quite expensive meter for identifying lights that are no longer capable to cure material. So look to some options. And again, if any of you have questions, we can certainly help with knowing where and what's out there to have your lights tested. So with that said, again, the big takeaways are light design and their performance has a huge impact on the consistency of your procedures you're doing day in, day out, and the quality of the equipment, as well as the materials. But there's lots of good materials, but good quality equipment is really important. As I mentioned about the curing times, for the materials drive the requirements or the curing protocol. So look to what the material needs. And then, of course, as the curing light operator, making sure to protect your eyes, position, and stabilize the light. This will absolutely address any curing light issues in your practice. And with that said, it's really important to continue, becoming educated on new technologies and new techniques and what's actually going to make a difference for your practice. So I really hope some of this education is going to help you the next day you're back in clinical practice, to be aware of some of these operator issues that certainly can be mitigated or avoided altogether, to make sure that light curing is never an issue in your practice.